Afternoon. Good afternoon to the East Coast and good morning to everyone else. And welcome to today's webinar, Produce RX, Addressing Inequity and Promoting Health During the Pandemic and Beyond. The Center for Health Law and Policy Innovation of Harvard Law School, together with the Rockefeller Foundation and the Aspen Institute's Food and Society program, are grateful that you've joined us today for a look at how a relatively novel food intervention known as produce prescriptions is addressing nutrition-related health concerns, particularly during the COVID-19 pandemic. And today, we're going to look at how produce prescriptions can be scaled to reach more individuals for whom they would be effective. My name is Sarah Downer, the Associate Director of the Whole Person Care Program at the Center for Health Law and Policy Innovation at Harvard Law School. And I will be moderating this webinar today. And to reach me and some of the other moderators, you can use the Q&A feature. So we will be taking questions at the end of today's presentation, and that is where you can put your questions, and hopefully we'll be able to have our wonderful lineup of presenters answer them. And so I just want to start off by defining the term produce prescription, which we'll be using today, and we will be referring by that term to the receipt of fruits and vegetables. So either you receive the actual produce itself, or more commonly, and for all of the programs that we'll be looking at today, you receive vouchers or financial support targeted to fruits and vegetables, and you would receive them at the recommendation of a healthcare provider. So this is a concept that's really emerged and taken hold in the last decade, and particularly within the last 5 years, as our country tries to respond to high rates of diet-related chronic disease and food insecurity. And really in this moment with COVID-19 changing the way that society works and threatening economic livelihoods and economic stability, the prospect of integrating produce prescription into the healthcare system holds enormous promise for helping to keep individuals and communities as healthy as possible as through access to good nutrition as this goes on and even beyond. So we should say at the outset of this webinar that the root cause of these high rates of chronic disease, widespread food insecurity, are in many ways the results of hundreds of years of structural and institutionalized racism and discrimination in our healthcare, public health, and food systems that have resulted in deep inequities in healthcare access, healthcare quality, and deployment of public health resources across communities. And access to healthy food. So produce prescription programs, they do not and they cannot dismantle those root causes of health inequities, and we all need to be doing broader system reform work, and that has to go on in parallel to any efforts to establish and scale these programs. However, they can serve as one mechanism to really prioritize resources in our healthcare and public health funding to individuals and communities that have experienced unequal access to fruits and vegetables. We have a really jam-packed agenda today, so I'm going to jump right in with a quick overview of who we'll hear from. We're going to hear remarks from the Dean of Tufts Friedman School of Nutrition Science and Policy, Dr. Dariush Mozaffarian, who's been writing and speaking extensively about COVID-19 and nutrition, and we're really happy to have him today. Following that, we'll look at several produce prescription programs across the country and talk about how they're continuing to deliver support to purchase produce even in the midst of this pandemic. Next, we're going to hear from clinicians Ileana Vink and Jackie Fanganello about what the ability to prescribe produce means for their patients and for them in their clinical practice. And we're going to ask a representative from a Medicaid managed care organization in DC, Ryan Springer of AmeriHealth Caritas, why a health insurance company is using resources to support and study the impact of this kind of program. Then we're going to shift gears a little bit and closely look at opportunities to expand and truly integrate produce prescriptions into the healthcare system in the short and intermediate and long term. And hopefully we'll then have some time for Q&A. So we are so pleased to be joined by so many people today. We're really overwhelmed by the attendance, and we'd love to be able to answer your questions. This webinar will be recorded, and the recording and slides will be made available following the presentation today. And so now, without further ado, Dari, I'm going to turn it over to you, and please kick us off.
Thank you so much, and it's such a pleasure to be here with everybody on the webinar to be talking about what I really think is one of the most important nutrition interventions that we can be adding on to our healthcare system right now. This is produce prescriptions, and so I'm really grateful to the Rockefeller Foundation, to the Aspen Institute, and to the Harvard Center for Health Law and Policy Innovation. If I could have the next slide. So, even before COVID, nutrition was at the top of the list of global priorities. This is the top issue for health and well-being in the world, whether it's for chronic diseases or for undernutrition. This is a major influence on disparities with diet-related diseases and a vicious cycle of poverty for many Americans and many people throughout the world. This is a huge issue for healthcare costs and access. Diet-related chronic diseases are the overwhelming majority of healthcare costs in our country. Healthcare costs have skyrocketed almost at such a rate that it's hard to wrap our mind around it. In 1970, the average federal expenditure on healthcare was about 5% of the budget. Now it's almost 30% of the budget. And so it's really swallowing all other priorities. And this is also true for private business and economic growth. Their budgets and their ability to raise real wages have been really hindered by rising healthcare costs. And again, much of this is due to diet-related illness. Food and nutrition is a huge issue for how we use our natural resources, agriculture, sustainability, climate change. We won't talk about that today, but it's enormously important. And it's also important for national security, where nearly 3 in 4 young Americans can't enroll in the military. They're disqualified. And the number one medical disqualifier is actually obesity. Next slide. If I could, thank you. And so, this was all true, again, before COVID, and COVID has really laid bare and shown these cracks and major problems in our food system. This is true for immunity, understanding how nutrition can affect directly immunity and health responses around COVID. This is true for the shocking and terrible rises in food insecurity, almost a doubling of food insecurity in our country due to schools that are closed, jobs that are lost, wages that are gone. And this is true for fractured supply chains, which is harming farmers and restaurants and all sorts of other aspects of the food system. This is true for seniors and hidden hunger. Many seniors have hidden micronutrient deficiencies, and these are being worsened by COVID and may also be contributing to the poor outcomes in seniors with COVID. This is central to the comorbid risks for COVID. Obesity, diabetes, hypertension, chronic kidney disease, cancers, these all raise the risk of poor outcomes with COVID by 3 or 4-fold each, really huge risks. And it's very possible if we had a metabolically healthy population that COVID would have been much less severe and we wouldn't have stressed our hospital and had to shut down our economy and lost trillions of dollars. And so as we think about having a resilient population for both COVID in the months and years to come, but also future pandemics, we really need to get our handle on food. As mentioned, and central to all this is disparities. People of color, Black Americans, Brown Americans, low-income Americans of all races and ethnicities suffer the worst of all of this, and that's not okay. It's not okay morally, and it's not okay for the economic and health consequences for those Americans. So for all of these reasons, food and nutrition, I think, are as important, if not more important than ever, in a COVID-19 world. Next slide. So, just a few statistics, and again, the numbers are so large, it's hard to get our minds around it. There have been more than 40 million new unemployment claims, and so that's about 1 in 5 working Americans have become newly unemployed. 124,000 schools have been closed at different times, and so that's 55 million children not getting school meals. And for many of these children, they're actually majority of their daily calories come from school meals. Closed restaurants, and not only closed restaurants, but all the cafeterias where we eat has limited the ability of people to access food. the disrupted supply chains, farm food being thrown away because it can't get to those who consume it. And so this has been just a devastating impact on food insecurity. Next slide. And I mentioned diet-related comorbidities. This is really important to emphasize because fruits and vegetables can help with many of these conditions and help fairly quickly for diseases like diabetes and hypertension. This is from one analysis from New York City, but having any one of these conditions raises the risk of a poor outcome with COVID substantially. And if you have 2 or 3 of these conditions, those risks become multiplicative. And so if you have obesity and diabetes, that's about a 12 times higher risk of hospitalization. And so a lot of the incredible stress to our healthcare system and our economy could have been prevented if we had a metabolically healthy population from healthier eating. Next slide. And this is not small change. When we talk about diet-related illness, these are big problems. Half of all adults in our country, half have diabetes or prediabetes. More than half have some form of cardiovascular disease. And almost 3 in 4 are overweight or obese. And so if you actually put all that together along with high blood cholesterol, only about 12% of adults are metabolically healthy. And so the vast majority of adults are actually sick. And this especially hits for low-income Americans and other disadvantaged groups. Next slide. And I mentioned this, but just looking at the numbers, it's just so shocking. This incredible rise over 40 or 50 years in healthcare spending, much of it related to diet-related illness, about 30% now of the total federal budget and total state budgets. And we're talking about hundreds of billions of dollars in potentially preventable healthcare spending. Next slide. And if we look at foods that we think are important based on the science, there's foods that are really good for you that we really need to emphasize in the food system. There's foods that are kind of neutral in the middle that you can have, and it's okay to have neutral foods. And there's foods that are really bad for us. And among the foods that are really good for us, foods like fruits and nuts and fish and vegetables and whole grains and beans and yogurt and plant oils are clearly at the top for having a healthy population. And so, I like the term produce prescription programs because many of these programs subsidize and incentivize more than just fruits and vegetables. But even just fruits and vegetables is a very important target to improve the health of the population. Next slide. Now, when we think about food as medicine, there's a range of ways to integrate food into health. But to me, the fundamental issue is to integrate food and nutrition into healthcare. Healthcare is where all the dollars are. It's, as I said, 30% of the federal budget. It dwarfs, the federal nutrition assistance programs. It's almost $1 in $5 in our entire economy. And so until we get food and nutrition integrated into healthcare, we're just going to be dancing around the edges. There's so many billions of dollars in healthcare that we could be leveraging and spending better. And among the different interventions, produce prescription programs are really valuable because they target sort of the at-risk population. The sickest, most chronically ill patients can be targeted by things like medically tailored meals. The whole population, of course, should have ways to get healthy food. There's a crucial importance for our nutrition assistance programs for people who just actually don't have dollars to buy food. And produce prescription programs hit in the middle. People who have specific conditions like type 2 diabetes or cancer or heart disease and could benefit from a prescription from their healthcare provider to go and buy and get a discounted or even free package of healthy food. Next slide. And so this has been tested in some early studies. This is one example from Geisinger Health. They took patients with type 2 diabetes who were food insecure and gave them, for their whole family, free healthy produce, fruits, vegetables, whole grains, chicken or fish. And they found that they spent about $2,400 per person per year, so about $200 per month. That's significant, a significant expense to give them this healthy produce. But they saw incredible clinical results. Hemoglobin A1C, which is a marker of diabetes control, dropped 2.1 points in about a year and a half. That's shocking. You don't see those drops with any single drug or even combinations of drugs for type 2 diabetes. And importantly, I think crucially, this even counting the $2,400 spent on the produce, saved money for the healthcare system. Tens of thousands of dollars in savings in less healthcare system costs. And so net, this saved money. And there's very few things in healthcare that actually save money. Even things like blood pressure treatment and control or cholesterol treatment and control with drugs, those things cost money. They're cost effective. You buy health for a reasonable amount of dollars, but they don't actually save money. In this analysis and some other analyses, produce prescription programs may actually save money. That's almost unheard of in the healthcare system. Next slide. And we did a modeling analysis. What if fruits and vegetables were provided at a discount to everybody in federal health care, to everybody in Medicare or Medicaid, not just high-risk patients? And we found that at 10 years, if you just gave discounted fruits and vegetables to everybody in Medicare and Medicaid, let's say you could get a card like a EBT card for Medicare or Medicaid and use it to purchase discounted healthy foods, that it would be just as cost effective as primary prevention of cholesterol, which of course we know is a best buy. And so even if we gave discounted fruits and vegetables to everybody in Medicare and Medicaid, this would be, by our estimates, as cost effective as the other incredibly cost effective things we already do in healthcare. And as I showed on the previous slide, if you target produce prescriptions to specific at-risk populations, it might even be cost savings. And so the health and equity and economic arguments are overwhelming to test and expand these programs throughout the country. Next slide. And, I think this isn't the only thing that's needed. There are other ways we need to create financial rewards for healthy foods. We need to have greater public education on the demand side. We definitely need to leverage healthcare dollars through produce prescription programs and other food as medicine interventions. But we need to do other things. We need to have tax policy that rewards companies for creating and distributing healthier foods. We need to expand the existing opportunity zones legislation, which gives companies tax breaks, but do it focused on healthy food and nutrition companies. We need to catalyze entrepreneurship. There are many, many companies from AI to behavior change to consumer packaged good products that are trying to create healthier products. We need to catalyze that with a new national system of entrepreneurship. We need to expand B corporations, companies that are dedicated to social commitments as part of their profit motive beyond just cash. And we need to shift this into ESG, the way that investors invest in companies. These things together will make healthier food more affordable for everyone. Next slide. And so this is already happening. The Farm Bill put in $25 million total to test produce prescription programs. That's wonderful. It's of course a drop in the bucket in the Farm Bill, but it's a wonderful start. California is spending to test medically tailored meals. Kaiser Permanente has launched Food for Life to really integrate food as medicine into their system. John Hancock is actually paying for healthy food for their life insurance customers and has just launched a new program called Aspire for patients with diabetes. And Massachusetts, the state of Massachusetts, has a wonderful bill, a food and health pilot program, which has been proposed but not yet passed to test many of these interventions in Massachusetts. Next slide. And so I think that, just in my opening remarks, I tried to highlight how important food and nutrition is, how COVID has actually shown it's even more important than ever, in particular for health disparities, and how integrating food and nutrition into healthcare in particular and produce prescription programs as a top example, we have to do this, and we have to do it now this year, I think, as part of these COVID relief packages to really implement and test produce prescriptions throughout federal insurance programs. It's time really for a national moonshot to fix our food system, and this will help, lower healthcare spending, create equity, improve what we know about nutrition through critical nutrition research, and give us a resilient and healthy population, both for COVID and for future pandemics. So thank you very much for listening, and I really look forward to the rest of the talks.
Thank you so much, Dari. You've really done an incredible job of setting the stage for today. And now we're going to turn to leaders of 4 produce prescription programs operating across the country, and we're going to ask them, what do these programs do and how are they doing it, especially in this environment? So joining us today, we have Andrea Talami, the Produce RX Program Manager at DC Greens in the District of Columbia, Alyssa Avanen, the Project Director of Complete Eats RX at the Washington State Department of Health, Sissy Bonini, the Executive Director of Vouchers for Veggies, Eat SF in the Bay Area in California, and Neil Curran, the Director of Food Programs at Reinvestment Partners in Durham, North Carolina. So Andrea, we're going to start with you and ask you to please tell us about the Produce RX program operating in DC in partnership with a Medicaid managed care organization, and just let us know sort of how COVID has affected your initiative as well.
Sure. Thanks for the introduction, Sarah. Just before I go into detail about the Produce RX program, I just want to share a little bit about what DC Greens is about. So we're a nonprofit organization here in the nation's capital. We work to advance food justice and health equity in the nation's capital. And, Washington, D.C. is not only our nation's capital, but it is also one of the top 5 wealthiest metro regions in the whole country. And regretfully, this wealth has not protected many of our city's residents from health and food inequities, and which is why we do the work that we do to address some of the issues we see in our health and food system. So today I'm going to talk about the Produce RX program, which allows medical professionals in Washington, D.C. to prescribe fresh fruits and vegetables to Medicaid patients experiencing diet-related chronic illnesses, including hypertension, diabetes, and prediabetes. So DC Greens started running the Produce RX program back in 2013. And during the first 7 years we offered the program, we did it in partnership with clinics, the farmers markets, and DC Health. And while we received a lot of positive feedback from participants and partners and our stakeholders, we knew that in order to scale the program and make sure it was sustainable, we knew it was important to be able to offer the program year-round, which had previously not been possible due to the seasonal nature of farmers markets, and also to be able to show the impact of the program and work towards integrating the program in the healthcare system. So in 2019, so just last year, we partnered with managed care organization AmeriHealth Caritas, which you'll be hearing more from Ryan today, supermarket chain Giant Foods, 6 federally qualified health centers, DC Health, and Socially Determined, an analytics company, to launch a new model of the Produce RX program, which is now at the grocery store, and to conduct a year-long evaluation to understand the impact of produce prescription programs. So in this new model, healthcare providers from partner health clinics write prescriptions for $20 per week for patients who are then able to take that prescription to the pharmacy at Giant in Ward 8, where the prescription is redeemed for vouchers that deduct the cost of fresh produce from their grocery bill. So the prescriptions are good for 90 days, at which point patients go back to their doctor for a well visit and renew their prescription. This model of the program, we are hoping that not only increases access to healthy food, but it also incentivizes patients to have a better relationship with their provider and be more engaged with their health. So as part of the program, patients also are able to access nutrition education resources from their health plan, AmeriHealth, and Giant, who has hired an in-store nutritionist to offer individual consultations and workshops for Giant customers and also our Produce RX participants. So what we think is very exciting about this pilot intervention is that we are collecting clinical data, survey data, participation data, purchase data, health claims data as well, to really do a robust evaluation of the Produce RX program and be able to have a better body of evidence for the impact that these programs can have on individuals' health. So this last piece of data, the health claims data, is extremely important as we think that it will allow us to have a better understanding on the return on investment of the programs, to be able to look at healthcare costs. And we're also hoping to see through this evaluation any impacts on patient-provider relationship, any impacts on health outcomes, as well as food security. So as I said, we hope that through this evaluation, we're able to provide evidence that supports the effectiveness of these programs and to help us build that case for the integration of these programs into the healthcare system. So currently the program is offered only in Ward 8. This is a pilot project. Ward 8 is the highest poverty area of Washington, D.C., also where we see disproportionate numbers of diabetes, any other chronic disease, as well as food insecurity. And through the program, we are currently serving 650 AmeriHealth members. So far, we have distributed a total of $86,000 and have a redemption rate of 80%. The program launched in April of last year, and we will continue to offer the program and collect the data for the evaluation until December of this year, so 2020. And we're hoping to have preliminary results of our evaluation in the spring of next year. So stay tuned for that. And just to talk a little bit about how COVID has impacted our program, in the last few months due to COVID, we have had to make a few modifications to the program to make sure participants are able to access the program while our clinics and hospital systems adapt to the current situation. We're also thinking about longer-term modifications of the program as we foresee some of these changes to the healthcare system, such as integration to telemedicine, to continue, and we want to make sure that we adapt our program to those changes. One of the benefits that we've seen from having existing partnerships in the healthcare system, especially during this time, is that we're able to think creatively with them and to develop programs that respond to the current situation. And we're now offering a COVID support program that delivers 2 weeks worth of food for patients who are asked to self-quarantine due to COVID-19 and who are food insecure. Just to close, I think COVID-19 and the resurgent social movement we've seen in the last few weeks has reinforced the need for our programs, for programs that can protect the most vulnerable populations and ensure more equitable and effective healthcare and food systems for all. And we believe this crisis really has heightened the need for the food as medicine initiatives. We continue to work to make sure that we continue to scale these programs, make them more sustainable and integrate them into the healthcare system. And just to echo what Dari said, we think this is the right time to do that.
Thank you so much, Andrea. And I have seen a few questions come in the Q&A that ask about the availability of the slides and the recording. Then everyone who has signed up for this webinar will receive a link to the recording and also the slides. And then for Andrea, you've done a fantastic job of sort of laying the groundwork of what a Produce RX program looks like in practice. And so I'm going to ask our next speakers to really, you can echo what Andrea said and then draw some contrasts for your own programs, just so that we stay on time. So Alyssa, I'm gonna invite you to talk about Washington's Complete Eats program.
Great, thanks, Sarah. Hi, everyone. Like Sarah said, my name's Alyssa Avanen, and I manage the Fruit and Vegetable Incentive Program at Washington State Department of Health. And one component of our fruit and vegetable incentive strategies is a produce prescription program called Complete Eats RX. And the goals of Complete Eats RX are to improve food security and increase access to and consumption of fruits and vegetables among low-income patients. For a bit of background, this work began in 2016 with the USDA Food Insecurity Nutrition Incentive Grant. The program is coordinated through us at the Department of Health and is a partnership with Safeway and 12 different healthcare systems and public health organizations throughout the state. This includes 4 federally qualified health centers, 1 tribal health department, and other organizations that serve patients with limited incomes. So eligible patients are those who receive care through one of our 12 partners and screen positive for food insecurity and then have or are at risk of developing a chronic condition. So our partners use the 2-question hunger vital sign food insecurity screening tool. And one thing I'll point out here is that we in Washington State, we haven't been incredibly prescriptive to our healthcare partners about who within their patient population should receive these vouchers. So the healthcare partners tell us before they begin the program, we want to provide these vouchers to our patients with type 2 diabetes who have food insecurity, whereas another organization might focus efforts on patients who have obesity or hypertension and are food insecure. So that flexibility is kind of built into our program. With the funding that we currently have, approximately 2,000 patients receive vouchers each year, and patients receive $250 worth of vouchers over the course of 6 months from their care providers. So that's roughly $10 per week. These vouchers can be used at any one of 170 Safeway stores in Washington for fresh, canned, and frozen fruits and veggies. And I mentioned that this work started in 2016 with federal grant funding. And in 2019, our state legislature created a state-funded program to continue fruit and vegetable incentive strategies, including Complete Eats RX. So the state legislature passed that bill and then also appropriated funding for the 2019 to 2021 biennium. So that's the source of funding that we're currently using to run the program. As far as how Complete Eats RX has been impacted by the COVID-19 pandemic, first and foremost, our healthcare partners are reporting a substantial increase in patients experiencing food insecurity over the past few months. I've probably heard most from our federally qualified healthcare centers that largely serve the Latinx community. One of the ways that we're trying to meet this increasing demand for the vouchers is through requesting CARES Act funds that have come into our state. So we recently put in a request, or are putting in a request for a CARES Act fund to temporarily scale up the program to meet that need. Outside of finding ways to meet the increasing demand for vouchers, we've also had to be flexible with how the program is administered. Like Andrea said, we're making kind of changes as we go. So typically the vouchers are handed out monthly or quarterly to patients when they see their care provider for an in-person appointment. But many of our healthcare partners are now using telemedicine and remote services for patient visits. So they actually send the vouchers to their patients in the mail. And I guess just in closing, and as Sarah said at the top of the hour, from a health equity lens, we know that these vouchers don't necessarily dismantle root causes of health inequities in our country that are definitely being exposed right now, but we do think that they are one small mechanism to prioritize healthcare and public health funding, frankly, for people that have been historically marginalized. So with that, I will turn it back over to Sarah.
Excellent. And I'm going to go ahead right away and invite Sissy to talk about the Vouchers for Veggies program.
Vouchers for Veggies EDSF is a program, we launched this program in 2015, really responding to the food insecurity and health disparities in San Francisco. And it's just really grew very rapidly. The program structure, to kind of compare and contrast to some of the other Veggie RX programs, we are a little bit of a hybrid. So we have our typical produce RX components that we work with clinics in hospital settings. But we also work with other community-based organizations, really meeting folks where they're at. So housing sites, senior centers. We have a partnership with San Francisco Department of Health WIC program to work with our pregnant folks. So it really a little broader healthy food purchasing supplement and healthy eating program as well. Another interesting aspect of our program is our vendor locations, and again, we are really focusing on addressing those the food security and health disparities. So those are more prominent in certain neighborhoods, and those neighborhoods typically are also some neighborhoods that have less access to healthy food. So one of the things we have is we have a network of corner stores, grocery stores, and farmers markets to really try to address folks where they're at, and specializing in those underserved neighborhoods. Our reach is, we're doing about 5,000 households annually right now. Our program is $20 to $40 a month, depending on your household size. And we run for a minimum of 6 months because you need to get in that habit of eating fruits and vegetables and integrate it into your diet. And again, we are the purchasing supplement plus nutrition education. Our eligibility is really flexible. It really depends on the needs of our funders, the needs of the organizations that we're partnering with. Across the board, the most common eligibility is screening for food insecurity, plus being a pregnant person, an older adult, having a diet-related chronic disease, or, in some cases, other particular vulnerabilities that make it really important for you to have access to healthy foods. Again, our funding sources are varied. We have the significant amount of funding comes from the San Francisco Department of Public Health. And also in San Francisco, we passed a sugary beverage tax. So we are a recipient of that as well, which is super helpful funding source. Also, a lot of grants and philanthropy, grants such as AARP Foundation that has really helped us optimize our program for national replication and meet those needs of older adults across the country. So in terms of the COVID response, so our regular program is, even though we serve 5,000 households, we still have a wait list of another 6,000 households. I mean, it's just a super popular program. And sure enough, so when COVID hit, it wasn't terribly surprising that we immediately had a lot of our clinics and partner sites looking for some help for some of their vulnerable clients. So we were able to leverage this unique infrastructure that we had with those corner stores and grocery stores across the city. And we produced not only our fruit and vegetable vouchers, but also these special COVID vouchers that were good for any food item except for alcohol and sugary beverages. And we were able to get those out very quickly. In about 8 weeks, we will be distributing over 100,000 vouchers, reaching another approximately 5,000 households. So, and we're really focusing on pregnant folks, folks with families with children, older adults, again, and those folks like, San Francisco General Hospital Diabetes Clinic. They're just super in need of this healthy food, especially during this particular COVID time. As Andrea talked about, I think a lot of us had to also retool our operations for COVID for telehealth. So we're doing a lot of remote enrollment now, as well as mailing vouchers.
Thank you so much, Cynthia. And I also saw a question come through that asked what the difference is between vouchers and prescriptions. And I just want to mention that before we head on to Neil. So the term prescription, so if you think about a prescription medication, that is a medication that you need a prescription in order to get. When we're using the term prescription in relation to produce, it's used very informally and loosely. So this is a term that has been adopted into this lexicon here. So you do not need a prescription sometimes to get access to these things. But sometimes they're called produce prescription to highlight the link between the healthcare system and the food system. But what it is the healthcare provider sort of recommending that you have a voucher or some kind of other mechanism to get support for these foods or to get the actual foods themselves. So it is not a technical prescription. It's just a term that is being used in this context. All right, Neil, I'm going to ask you to come on and chat about the program in North Carolina.
Great, thanks. Yeah, that's a great point. The prescription is the voucher or the dollars. I think that's a key distinction. My name is Neil Curran. I work for Reinvestment Partners. We're based in Durham, North Carolina. Our mission is to foster healthy and just communities by empowering people, improving places, and influencing policy. So we began our program in May of 2018. Where between then and now, we've expanded to include 42 counties across the state in the program. Approximately 200 stores are participating, and we've enrolled, as of today, about 2,400 patients. The vision of our program I guess to step back for a second, the vision of our program is much like we've heard from other folks and at the top of the webinar, is to really see this type of program, this money for food, for healthy food, embedded in the healthcare sector as a way to address food insecurity as a social driver of health. Our goal to reach that vision is to create a program that can scale across a large geographic region and serve a lot of people, but also serve a targeted population, and also track the utilization in the program for evaluation purposes. So each of those factors is kind of has helped us drive our design of the program and informs our vision of seeing this embedded in the healthcare sector. I guess, so we serve SNAP beneficiaries who are receiving care for a targeted clinical condition, and we partner with typically folks who are care managers at participating clinics. We think that partnering with, these types of programs, the sweet spot for them is really that wraparound patient support space, like what you've heard from other folks on the call, working with either some sort of nutrition education component with an RD. The healthcare sector, as I'm sure many of you all are aware, that's an existing asset that we found has been really helpful to work with in getting these dollars out the door. So yeah, I guess broadly speaking, our program uses a electronic coupon digital voucher style of benefit distribution. So $40, each patient gets $40 per month loaded onto their customer loyalty card at the participating retailer, which is Food Line in our neck of the woods. And the money gets loaded onto the card, and they just send it down as the tender of first resort for eligible items, which are fresh and frozen and canned fruits and vegetables with no added salt, sugar, or fat. So I think we see our program as working really well for patients, providers, and payers. So for patients, it functions just like a coupon would, or it's as close to a cash transfer as you can get, right? There's an equity piece baked in there. It's also redeemable at places where a lot of folks already shop. Food Line has 500 stores across the state, so they have a pretty good reach, and it's easy for folks to shop there. For the provider, kind of riffing on what Sarah was saying earlier, this is a material benefit. It's not a referral. It's an enrollment into a program. Folks can walk out the clinic that day and spend the benefit. So yet it doesn't require the clinic to, store boxes of food in the clinic, right? So I think that's an important design element. We're also focusing on primary care, as a way to move this from, as part of the broader move in healthcare towards bolstering primary care and preventing, focusing on prevention rather than treatment. And then we also have a telehealth component. And for the payer, like what Cece said earlier, where the program has some flexibility and is able to address different populations based on the payer's needs. I'll say that we get funding from a couple different places. The USDA's Food Insecurity Nutrition Incentive Program and the Gus Schumacher Nutrition Incentive Program are key funding sources for us. We're talking about that a bit later. And then lastly, we did get $2.5 million from the state of North Carolina through the CARES Act, like what Alyssa was saying they're trying to do in Washington. We were successful in getting that money. And kind of the selling point there was, this is an efficient model for distributing dollars quickly. You don't have to rely on volunteer networks or donations. So that's kind of how our program has shifted in response to COVID.
Thank you so much, Neil. So now we're going to ask for some clinician perspectives on these programs. I think Neil made a great segue into that with his remarks about focusing on primary care. Joining us today are two registered dietitians who administer this program where they work with patients. And then we'll also chat with someone who works at a Medicaid managed care organization about why that organization is supporting these kinds of programs. So we welcome Jackie Fanganello, a registered dietitian and chronic care coordinator at the Mission Neighborhood Health Center in San Francisco, where she works with the Vouchers for Veggies program, and Ileana Vanka, clinical dietitian at Duke Well in Durham, North Carolina, where she works with the Reinvestment Partners Produce RX program. So I'm going to pose my first question and for the clinicians, and they can each respond, and then Ryan, will move on to you in just a moment. So for Ileana and for Jackie, how do you use produce prescriptions in patient care, and what value do you think they have for the patients and then for you as a practicing clinician? So Jackie, we'll go ahead and start with you.
Hi, my name is Jackie. I'm a dietitian at Mission Neighborhood Health Center. So at my clinic, we serve a mostly underserved and uninsured immigrant population. Most of our patients are monolingual Spanish speakers, 76% of which live below the federal poverty line and are at higher risk of food insecurity. We also have 3 primary care sites, and we serve 12,000 patients per year, many of which who have chronic health conditions. So with the ESF vouchers, they've been able to greatly impact our patients in positive ways. So for example, last year I led 2 diabetes prevention workshops. Participants were overweight and obese adults with an A1C in the pre-diabetes range. The cohort with the ESF vouchers had better health outcomes in that we had more participants who lowered their A1C and lost weight in comparison to the cohort that did not receive the ESF vouchers. Some even lowered their A1Cs back to normal range and were able to decrease their risk of developing type 2 diabetes. We also had a 3-month follow-up with participants, and they still had 2 months left in the ESF program. And participants told me that they were able to use what they learned in the workshop and the vouchers to teach their children how to incorporate more healthful foods, such as whole fruits and vegetables, in their diets. They also stated that it wouldn't have been as feasible had they not had the vouchers. So this has also been very helpful in helping our patients expand their self-efficacy and reporting more energy, looser fitting clothes. And one of my favorite things is that when I see them at follow-up, I can just see how great they feel. Their smiles on their faces, their eyes lighting up, because they just feel so much better with the health outcomes that they have been able to have.
Jackie, that's amazing. And I'm going to return to you in just a moment, talk about how COVID has impacted your patients. But Ileana, I wanted to also just offer the same question to you. How do you use these prescriptions, and what value do you think they have?
So I was connected with Reinvestment Partners program through Duke Outpatient Clinic, where I spend part of my time, and that clinic has a very high rate of folks who are uninsured or have Medicaid insurance. And the other hat I wear is care management through Duke Well. So I'm part of an interdisciplinary team working with patients who've been identified by their medical providers or by their insurer as patients who are having a tough time managing chronic medical conditions, and also often dealing with social determinants of health that are making all those self-care behaviors so much more difficult. I think care management is a really, as Neil was saying earlier, a really great setting for these kinds of fresh produce interventions, because we are already seeing the patients who are frequently in the emergency room, frequently admitted, having difficulty managing a chronic condition, often related to issues like food insecurity. And I work with patients with a variety of chronic illnesses that have those nutritional implications, like were discussed earlier in the presentation. So diabetes, congestive heart failure, chronic kidney disease, high blood pressure. I see a lot of those things. Being in North Carolina, it's interesting having patients who a few generations back may have been living on a farm. So we've had a pretty abrupt transition in our state where people are now relying on these processed convenience foods, fast foods, but when they see fruits and vegetables, they recognize them, they enjoy them, they get excited to have them. And something that's missing is the access piece, and recognizing that people, when they have a limited income, when they have to make choices like deciding between paying the rent or buying the groceries, they are going to choose foods that are higher calorie and are going to make them feel full, and fruits and vegetables might be viewed as more of an add-on item than something that really should be the foundation of a healthy diet. And so just having this intervention for the fruits and vegetables is huge. And we know that pretty much any chronic medical condition, if the quality of the diet improves with the addition of the fruits and vegetables, management of the condition will improve. I would also just talk a little bit about the idea of having to meet basic needs before we can do complex nutrition education. Of course, I'm a dietitian, I'm biased. I think everyone should have nutrition education, but we have a really limited capacity in our state and probably in other places. So if we look at our county, we have a very small number of dietitians to serve the Medicaid or uninsured population. And so having this opportunity where the education is built into the intervention, fruits and vegetables are good for you, here is money to buy them, it's kind of a way to have a broader reach without people having to jump through those hoops of nutrition education. And when people do have access to the nutrition education, when they already have this basic fundamental need met of having better access to food and healthy food and food that makes them feel good, there's this increased capacity to be able to take in nutrition education, which is complex, which can be complicated, which can involve thinking about, thinking ahead, thinking a whole series of steps, looking at something like diabetes, thinking about how am I taking these medicines, how am I getting them refilled, how am I getting all of my supplies, how am I using the blood sugar readings to evaluate the previous meals that I've eaten. Those are all complex things. And if we are able to deal with the chronic stress that comes with food insecurity, it just increases people's capacity to be able to engage with those complex topics. I also did just want to make a plug for partnering with a local grocery store chain when creating these kinds of interventions. I'm very passionate about farmers market interventions, and we do have some quote programs in Durham. At the same time, though, because as many people are noting in the Q&A and the chat, transportation can be a real barrier to people. The fact that we're having something at neighborhood grocery stores, which are open on the weekends, which are open in the evenings, which are more accessible to people, which may be more culturally familiar to people. You see your neighbors there, you see people who look like you. The farmers market may be an unfamiliar place. So being able to use those benefits in the local grocery store is something I think that makes it more accessible. And then one other thought that I had is just having access to all the WIC accessible fruits and vegetables is helpful now, and particularly with COVID, people are wanting to stock up at the grocery store. People are wanting to make fewer trips and have more shelf-stable items or, frozen items, canned items. And so having that option, I think, is a really big asset of Reinvestment Partners program.
Thank you so much, Ileana and Jackie. And Ryan, I want to go ahead and turn to you just in the interest of time so that we make sure that we can get to some of the solutions about how to scale some of these things. So we're going to turn now to Ryan Springer, the manager of Marketing, Communications, and Health Program at AmeriHealth Caritas, which is a Medicaid managed care organization in the District of Columbia. And this organization this health insurer has partnered with TC Green's Produce Prescription Program to help its Medicaid members access this intervention. So Ryan, can I ask, why did AmeriHealth stand up this program? And, as from the position of an insurer within the Medicaid managed care program, what do you hope that this will achieve for your members?
Good afternoon. Sarah, thank you to you and the planning team for having me on today. As mentioned, I'm with AmeriHealth Caritas DC, and we're the largest Medicaid plan in DC, serving approximately 120,000 enrollees. And the majority of our population are African American and living in district wards with the most significant health challenges and disparities. And so the reason why we got into this really was, leadership with great foresight. And so Karen Dale, who couldn't be with us today, she challenged the team to really think about what's our role within the social determinant space, and looking at the impacts on the clinical outcomes with our impacts. So kudos to Karen for that and getting us on the path to looking at this and other social determinant issues. So given the fact that the majority of our chronic disease issues in our community are in our the members that we serve, really. And so it was a natural fit to work with DC Greens to really implement this program and think of it as a way of addressing the diet-related chronic diseases that our enrollees are facing. And so this is one of multiple tools that we have. We also have a condition-appropriate home-delivered meals program. And so that's targeting several other enrollees who have chronic disease, or we're using it as a means as health security. So for example, folks who are being discharged from hospital, we contact them and offer them meals as well to make sure that they have that security in the home and they're able to recover appropriately. So we haven't had, as Andrea mentioned earlier, we don't have the final results of the study so far, but we've seen a significant increase over the last few months during the COVID pandemic. And of course, COVID has impacted everything about the work that we do, but we're excited to see that increase in utilization for the vulnerable population that we serve. And I'll make one point. There was a pilot work that we did with DC Green several years ago, and the outcomes of that showed that we had significant increased engagement between the enrollees and their primary care provider. And we're hoping that we see that continue with this pilot that we're running. And the importance there is that once we see our enrollees engage with the health system at one point of the healthcare system, we see that increase across their overall engagement in their healthcare. We're hoping to see that across the board. In terms of the analysis going forward, we're expecting to see, of course, improvement in clinical outcomes. And as a health insurer, we're hoping to see improvements across our HEDIS measures, from prescription drug utilization to potential screening, schedules, and other factors. And for the long term, we'd hope to see improvement in the knowledge, attitudes, and skills on a sustained level around how to seek and cook healthy foods over time.
Thank you so much, Ryan. One more question for you is, during COVID, what have, from your position within AmeriHealth, what has AmeriHealth witnessed, and does that change, how you see this program moving forward?
So there's a word that's been thrown around by several of the speakers, which I'm going to say again, and that's flexibility. And so it was really clear that we need to be nimble, flexible, and have a diverse toolbox of strategies to really address the needs of our enrollees based on where they are. We've seen some enrollees prefer home delivered meals, some prefer going to the grocery, and there are various fears and beliefs that influence those preferences. And so we're trying to make sure we have a cadre of options so that we can respond based on where they are.
Thank you. And, I think so far on this webinar, the folks have really made a powerful case for broadening access to produce prescription programs, particularly now and in the long term. But all too often, these programs are funded by philanthropy or time-limited grant funding, so they're not really built into and linked to the healthcare system. So the DC Greens AmeriHealth partnership is really unique in that these are the two organizations coming together to evaluate the clinical indicators that are going to change as a result of produce prescriptions. And that's not always the case. The research in this space has been, is still young, and we're still sort of figuring out how to evaluate the impact of produce prescriptions and healthy food prescriptions on clinical outcomes, healthcare utilization, healthcare costs, all of those things. And then some of the things that Ileana and Jackie referred to, which is, what is the impact on someone's stress level? What is the impact on someone's feeling about their ability to eat healthy and to sort of go about their day without worrying about food? And then also, thinking through as well, what is the impact on the household? So I've seen questions come through the chat about this. These are areas that we still don't understand very well. And so we are hoping that the Aspen Institute's Food and Society program, which has just launched a Food as Medicine initiative in this space, can help us with that, can help us find out more about what is happening as a result of this program. So Corby Kummer is here with us, the Executive Director of the Aspen Institute's Food and Society Program. Corby, can you tell us a little bit about the Food as Medicine initiative at Aspen and how it's going to lay some of the important groundwork for scaling these programs?
Thank you, Sarah. It is very exciting to be here working with Sarah, who is one of the chief architects of our Food as Medicine initiative, along with Emma Clippinger, and to be working with the Rockefeller Foundation that's doing such great work with increasing access to produce prescription and evaluating the impact of produce prescription interventions. We at Food and Society at the Aspen Institute identified a need to understand what is the research that can better support the current fantastic work going on in food as medicine interventions across the country. You saw some snippets of it in the great slides that Dari, my dean at the Tufts Friedman School of Nutrition Policy, showed at the beginning of this webinar about the different kinds of strategies and interventions, the pyramid that Chilpi and Sarah and her colleagues developed with Community Servings, which is going to be our host for a meeting on food as medicine interventions. But what we identified was a need for a roadmap. What is the research that will best increase access, best address the problems of uneven access and equity, best provide data to different payers, program providers, to increase these interventions, and we hope get them used and accessible in rural, underserved areas where they're currently unavailable and just don't exist. So we're bringing together the country's leading researchers, and I'm sure many of them are right on this webinar now, to help us understand the priorities and gaps. And we are going to be providing, with the generous support of the Walmart Foundation, that's our main funder for this initiative, a research priorities action plan that will be a roadmap for future funding for the next steps in the best research that will make for a robust national database that's going to help expand the integration of produce prescription into food as medicine interventions. So we very much welcome your ideas and your participation. And I have the addresses of Emma Clippinger, our wonderful senior advisor, who's also on this webinar. And our website is on this slide, which Sarah, thank you very much for distributing at the end of this webinar. So I'm delighted to be a part of this exciting field, and especially to get to work with and have as a thought partner the Rockefeller Foundation, which is doing such wonderful work in protective foods and produce prescriptions.
Thank you, Corby. And so, as Corby said, building the research and evidence base is so critical, because that's what's really going to help us convince policymakers to sustainably fund these services and actually understand who they best serve. I mean, Ryan talked about the need to be nimble and thinking about whether members wanted to receive meals or produce prescription, whether they want to shop at the grocery store or receive food at home. And there is so much that we just really don't still know about what these produce prescription programs can be and should be used for. So we're looking forward to diving into those questions together. When it comes to funding, there are really two options for how we're going to sustainably fund these programs moving forward in this country and ensure that they are available to respond to moments of higher need, like a COVID-19 pandemic. And so those are through agriculture, which is, I think, a less likely stream, but still available, and then through the healthcare system. And so Neil Curran of Reinvestment Partners is going to come back, and he's going to tell us about a program that was established in the most recent Farm Bill, the Gus Schumacher Nutrition Incentive Program Produce Prescription Pilot. And he's going to also talk about the role of the Nutrition Incentive Hub in helping to responsibly grow Produce RX programs. And then my colleague, Katie Garfield at the Center for Health Law and Policy Innovation at Harvard Law School is going to close by providing a brief overview of some of the health system opportunities for funding produce prescription. So Neil, would you go ahead and come back?
Yeah. So hey, Neil Curran again at Reinvestment Partners. As Sarah said, through the USDA's Farm Bill, funding was made available through grants to fund produce prescription programs. About $4.5 million per year are being made available in about $500,000 chunks through the Gus Schumacher Nutrition Incentive Program, or GUSNIP as it's called. So the map you're looking at here is a map of where both produce prescription programs and also a broader category of nutrition incentive programs called SNAP incentives are operating. So this just gives you kind of a lay of the land of what's out there now. These programs, they provide, for the produce prescription programs, they provide 3 years of $500,000, up to $500,000 for grantees that can be nonprofit entities or government entities to pilot these programs. And you can design the incentive however you like, but essentially it's what we're talking about. We're giving money to targeted patients for fruits and vegetables. Next slide, please. And as part of this grant funding through the USDA, they've also funded the Nutrition Incentive Hub. This is a consortium of experts from across the field and across the country that are tasked with providing technical assistance and training to prospective grantees and folks who are currently grantees to the program, all with the goal of strengthening access to fruits and vegetables. Next slide, please. And this gives you kind of an idea of who these folks are. The Gretchen Swanson Center for Nutrition is the lead on the grant, and they're co-leading with the Fair Food Network. And so they have a lot of expertise on evaluating these types of programs, looking at nutritional impacts. Then on the Fair Food folks, they've have a deep experience running these types of programs in Michigan and across the country. And so the point of bringing all this up is that these grants, the deadline for these are typically sometime in the spring. They come around annually. And so that's an opportunity for folks, to be thinking about that now, of how if you start brainstorming, if this is something of interest to you, think about what a project might look like in your neck of the woods with the collaborators in your network. And I'll also say that the Nutrition Incentive Hub provides free technical assistance to people looking at applying for this. So if you have questions, if you're interested in learning more on how to apply for these funds, I myself am providing technical assistance for produce prescription programs, specifically with grocery stores. So I'm available and can help provide some information. There's all the folks on this slide here also have expertise and are available for questions. I'll go ahead and throw up an email address in the chat box that folks can reach out to. So that's just a resource available for you all in the short run.
Thank you, Neil. And now I'm going to invite my colleague, Katie Garfield, to come on and give us a brief overview of some of the health system opportunities for funding produce prescription, and then also touch on how states and municipalities can use some of more immediately available pandemic relief funding to widen access to produce prescriptions in the short term. Go ahead, Katie.
Thank you, Sarah. In addition to the GUSNIP program that Neil just described, there are a variety of short and long-term funding streams that can be used to support, analyze, and scale, really, these produce prescription programs. And over the next few slides, I'm going to provide what's really a high-level overview of these opportunities. And let me note at the outset that my role here today is not necessarily to promote any specific approach, but instead to really inform you of the policy landscape, the great possibilities, and some of the remaining gaps. So let's begin with some short-term opportunities. As you've heard repeatedly today, produce prescription programs have faced significant challenges due to COVID-19, as have many organizations across the country. They've had to overhaul their programs to institute things like social distancing while coping with increased demand for their services. And with these new challenges come new and increased costs. Luckily, there are a number of COVID-specific funding streams that produce prescription programs can leverage to address their immediate need. And I've laid out some of those programs on the next two slides. First, there are some broad streams of funding created specifically to address COVID-19. These really include stimulus funds, FEMA funds, and state emergency funds. federal stimulus bills in particular provide significant support for COVID response. For nonprofit organizations, one of the most important stimulus opportunities is, of course, the Paycheck Protection Program. This program allows small businesses and nonprofits to apply for loans to cover payroll and other designated expenses. Importantly, if used on specific expenses, including payroll, these loans are forgivable. This means that participating nonprofits will not need to repay some or all of their loan. In addition to these stimulus bills, the federal government has, of course, historically provided emergency response funding through the Federal Emergency Management Agency, or FEMA. Food assistance programs such as private nonprofits that run produce prescription programs are eligible to apply for FEMA funding. If approved, FEMA will cover roughly 75% of the costs of work directly resulting from a declared emergency. And to learn more about this option, you can visit www.fema.gov. Finally, we know that states are engaged in their own efforts, as we've heard today from some of our participants, to address COVID-related costs. In many cases, states are doing so via their own budget or supplemental budget processes. But additionally, as again we've heard today, states are responsible for distributing many of the funds from the federal stimulus packages. Each state's approach to these funds will be different. Therefore, produce prescription programs can look to their state agencies and broader state government to learn more about their own region. There are also a number of short-term opportunities potentially available as part of the Medicaid COVID-19 response. Specifically, there are 3 categories of Medicaid waivers that CMS has encouraged states to apply for during the crisis. These waivers include sort of COVID-specific Section 1115 demonstration waivers, Section 1135 waivers, and Section 1915C waivers. Just to run through these quickly, Section 1115 waivers are really these highly flexible waivers that can be used to test new approaches to healthcare delivery and financing, including coverage of new services. While these waivers are usually approved for 5 years, as part of COVID response, CMS has really encouraged states to seek really these short-term 1115 waivers to address specific COVID response issues. In contrast, Section 1135 waivers allow states to waive very specific requirements such as licensing and prior authorization in order to ensure access to care during an emergency. And finally, 1915C waivers allow states to provide home and community-based services to keep individuals in their homes that would otherwise require an institutional level of care. In the event of an emergency, states may use what is called Template K to expand these 1915C programs to include new populations or new services. And notably, all of these opportunities are short-term, with timelines really tagged to the emergency period right now. They also have varying degrees of flexibility, which may impact whether CMS actually allows them to be used to cover nutrition services. So I want to say that there are limitations. However, I do want to highlight them here today because we know that a number of states like Illinois, Washington, and others are at least including nutrition interventions in their applications for these types of waivers. And regardless of whether or not those applications are ultimately approved, the fact that state Medicaid agencies are actively attempting to include nutrition interventions is a significant choice that sets an important foundation for future coverage. And that really takes me to what I see as the most important part of my comments here today. I want to emphasize that the issues that COVID-19 has highlighted, including food insecurity, chronic illness, and systemic inequities, are not short-term issues. These are long-term issues that require long-term solutions. So in addition to highlighting short-term funding opportunities, I want to start a broader conversation about approaches to sustaining and scaling produce prescriptions in the long term. This is a conversation that Chilpy plans to continue and report out on over the next year through a project with the Rockefeller Foundation. As you see on this slide, produce prescriptions sit at the intersection of our nation's food and health systems. While we know that this can be a challenge, it also means that we can look to both systems to identify opportunities to sustain and scale produce prescriptions. We've already heard about one such policy opportunity in the food system, GusNIP. So I'll now shift gears to really highlight opportunities in the healthcare system. Let's start with Medicare. So the Medicare program really provides some of the most concrete and expansive opportunities to support produce prescriptions right now. As a reminder, Medicare is our primary public health insurance system for individuals 65 and older. When enrolling, Medicare beneficiaries choose between 2 coverage options: Original Medicare, made up of Medicare Parts A and B, and Medicare Advantage, or Medicare Part C. Original Medicare is administered by the federal government and has historically provided no real coverage of food interventions. In contrast, Medicare Advantage is administered by private health insurance plans and provides more flexibility. Thanks to recent legislative changes, Medicare Advantage plans now have two very explicit options to cover produce prescriptions. First, plans may cover produce prescriptions as a supplemental benefit for individual enrollees who are coping with chronic illness. This option is known as Special Supplemental Benefits for the Chronically Ill, or SSBCI. The SSBCI option is available to all plans and must be submitted as part of the plan's annual bid. Second, plans that participate in the Value-Based Insurance Design Model, or VBID, may cover produce prescriptions as a supplemental benefit for enrollees who are chronically ill, low income, or both. To participate in the VBID model, plans must submit an application typically in mid-spring to the Center for Medicare and Medicaid Innovation. Opportunities are also emerging to cover produce prescriptions via Medicaid, our nation's primary public health insurance program for low-income individuals. As with Medicare, CMS has typically not allowed coverage of produce prescriptions or broader food interventions as part of the standard Medicaid benefit package. But again, initial opportunities and flexibilities are emerging, especially in the area of Medicaid waivers and managed care. Medicaid managed care organizations, the health plans that administer Medicaid benefits in many states, have a variety of regulatory flexibilities that really allow them to cover a wide range of services, including nutrition interventions. Specifically, MCOs may cover produce prescriptions as value-added services, in lieu of services, and potentially as administrative services that improve healthcare quality. And CMS has also announced that it is working on guidance regarding social determinants of health in managed care, which should really clarify these options further and help us to understand what are the best opportunities and ways to approach them. A number of states are also covering or planning to cover produce prescriptions under Section 1115 demonstration waivers, for example, North Carolina and Massachusetts. In contrast to the COVID-specific 1115 waivers I mentioned earlier, these more general 1115 waivers typically extend for a longer period, 5 years, and provide significant flexibility for states to test innovative approaches like produce prescriptions. But I want to close by noting that this is not a solved problem. Significant policy gaps still remain that prevent the widespread scaling of produce prescription that you've heard called for today. First, while, as I've said, there are a growing array of opportunities to fund produce prescriptions via the healthcare system, utilization of these opportunities remains limited and varied across the country. This may be due to a range of factors, including lack of awareness or lack of clear guidance about some options. Second, large gaps do still exist in our major healthcare systems. Large gaps still exist in Medicaid and Medicare coverage. And again, that's because coverage is not really built into the standard benefit packages. For example, 2/3 of Medicare beneficiaries are enrolled in Original Medicare, which doesn't really provide any option to cover produce prescriptions right now. And third, there's really an untapped potential that I want to highlight to partner with the food system. Scaling up produce prescriptions will require infrastructure, knowledge, and partners that may already exist within the food system, and food system policies such as GusNIP can provide other avenues for sustaining and scaling these programs. So there's a strong need to sort of share knowledge and expertise and partnership in this space as we move forward. And so let me end by instead saying that not that this is a solved problem, but instead that there is work to be done. There is work to be done to understand and address these gaps. And let me also highlight that there is work to be done to ensure that in filling these gaps, we are making sure that we're serving the individuals and communities that need them most. As Sarah stated at the outset, and as we've heard sort of echoed across this webinar, we know that our food and health systems do have a long history of marginalizing, ignoring, or abusing low-income communities, and particularly people of color. As a result, these populations are consistently the hardest hit when we encounter a crisis like COVID-19. Produce prescriptions can play at least a small role in responding to these inequities, but only if we build the policies and practices around produce prescriptions with a deliberate eye to addressing rather than perpetuating historical injustices. And with that, I'm going to turn things back over to Sarah and Bridget for Q&A.
Thank you, Katie. So we've heard from an amazing lineup of speakers today on the urgency for Produce RX programs, the diversity of program RX across our country, and the utility of these programs for clinicians and insurers. So I want to thank all of our speakers today, and we have a couple of minutes to take questions. So Bridget Carl from the Rockefeller Foundation has been following the Q&A. So Bridget, I don't know if there's anything you want to tee up. I've also been following it a little bit, so I can speak to some things as well.
Sure. Thank you, Sarah. And thank you, everyone, to all of the speakers for sharing your insights and time, and to all of those who joined today to hear more about how these programs are addressing diet-related disease in our communities today and the potential that they have to help tackle this nutrition crisis we're in if they can become more integrated into our healthcare system over the medium and long term, as Katie highlighted so well. As Sarah said, my name is Bridget, and I lead our Food as Medicine portfolio on the Rockefeller Foundation's Food Initiative. And thank you so much for all of these thoughtful questions. It's been an active Q&A and chat box to follow along. So I see that many of them have already been addressed, and I've tried to pull out a few and combine them so we can get to as many of your questions as possible. But hopefully this is also the start to a conversation for those that we cannot get to, and you'll receive the contact information and all the content from today's webinar afterwards. So to kick us off, the majority of the questions were for our program operators, Neil, Sissy, Alyssa, and Andrea. So if okay with you guys, I'll ask you a few of the questions and then turn it over to you to choose which of the ones you feel best suited to address. So the first one is, are there examples of healthcare paying for the vouchers or RX? And if so, how, insurance or provider? The second one is, how are these programs being evaluated? What outcomes and measures are used? How is this data collected? And if you could also mention how you track the redemption data of voucher cards, that has been asked. The third question is around, for all of these programs, are you focused on the patient and household members? Do you give more food to patients with more household members? And how do you calculate this? And lastly, there were a few questions on really helping people get access to these programs through technologies like food delivery, providing transportation, or offering telehealth. So I'll pause there and turn it over to you guys to see what you feel best equipped to address.
This is Alyssa. I can maybe take on an easy one and then hand it over to others. The easy one for me is looking at redemption rate. So we have paper vouchers, and basically for each healthcare system that we're working with, there's a specific barcode on those vouchers. So whenever a voucher gets redeemed at one of the Safeway grocery stores, we're able to see, yep, that was redeemed, and then what people purchased with the vouchers as well. And the vast majority of purchases are going towards fresh produce, like upwards of 90 to 95%. And we're able to see that from the redemption data from Safeway. One problem with how our model is set up, we do not have a way to link directly the voucher redemption directly to a patient. So we're kind of looking at it from a more like a health system rather than down to the individual redemption rate.
Yeah, I'm happy to jump in a little bit, talk about the redemption rates as well as the how do we collect data and evaluation. Similar to what Elisa's doing in Washington State, we are also using paper vouchers currently, and we are able to track with that barcode. The difference is because how we create the model of our program, a participant is basically follow through the whole program by a unique ID that is given at the point of enrollment at the clinic. So that unique ID goes into the EHR at the clinic, goes into the prescription. It's linked to the barcode that they receive on the voucher, and then we're able to know if that specific participant is redeeming. So that is something that we hopefully at the end of the evaluation, we're going to be able to look at the individual data at the individual level for the participants, how they use the program throughout the whole time. So, yeah.
Mrs. Sissy Bonini, I can talk a little bit about transportation. The whole idea of how to get food to people or people to food is, I think it's just a long-going problem in food security interventions in general, but of course with COVID it's just been really highlighted. I do think one of the things that these programs address is, having your vendor network that is close to where your folks live and work. So for example, we have corner stores on board to our vendor network because in the Tenderloin area in San Francisco, there's no full service grocery store. So people, they have to get out of their community to access through a grocery store. So we want to have if you can get a vendor network that is broader, people don't have to go as far. Also, we are very careful about making sure that our stores are on major transportation links like buses and things like that. Currently, because of COVID, we are doing a couple of different things, working with partners with Lyft to offer some transportation, and also we are looking into some apps to do the delivery. But I do want to say that we run into these challenges, and I think Andrea has the same thing with some of our working with folks that a lot of our folks are unbanked, very low income, or they don't have technology or phones that they can use some of these modern technology. So we do have these other challenges that are inherent for low income folks that we have to work around. But I think that's something that all of us are working on.
Hey, this is Neil, and I guess with our Alyssa's actually take the easy one. I think with the 2 minutes we have left, I'll attempt the hard one. Maybe two hard ones, just to really go for it. The one is around the question about healthcare, who's paying for it, right? Healthcare providers or payers. My answer to that is I don't know. It's a deeply unsatisfying answer. The landscape is changing all the time. I'm aware of some marginal investments. And I think maybe the trickier answer is kind of what Katie was getting to earlier around where does the money come from within the different buckets. So for example, are these community benefit dollars from the hospital system? Are these value added or supplemental benefits through Medicaid, an MCO, or a Medicare Advantage plan? Those are nice, and those are like basically, out of the goodness of a provider's or payer's heart. But I think with a vision for where we all want to get to is really into the covered benefit space. How can we make these expenses part of the medical loss ratio that payers are actually incentivized to use for that purposes as a covered benefit? And I think where a question related to that is around another one I've seen, or I think was brought up around evaluation. What's the evaluation program? And I think that, as was stated earlier, we don't know where that's going. I think something we all struggle with is the golden goose on all this is, does it yield healthcare cost savings? And that's a hard question to answer, right? People's diets or diet-related health conditions are, there's a lot of moving parts about what affects someone's life and their health outcomes related to their diet. And is a $40 or $80 a month benefit going to yield the results that we want to see to make the case for future investments in these programs? So I think those are important questions, and it remains to be seen. But I think there's maybe a broader question around what's the narrative and what's the story we're trying to tell for why healthcare payers and providers should invest in these programs, and what are the mechanisms to either, what's the carrot or stick to get them to do that? I think those are kind of the questions that I think are the most compelling right now in the space.
Thank you. Thank you, all of you guys. I realize that we're at time. I want to be respectful of all of our speakers, but I also wondered if Sarah and Katie, given your deep experience and how close you are to these programs happening across the country, if you have anything to add on those questions, or I'll turn it over to you, Sarah, to wrap us up.
Sure. So this is Katie. I'll just add, before kicking it over to Sarah, just a couple of quick additions on that question of sort of who is paying for these things. Again, as I said, a lot of the opportunities are really emerging right now. And so I think over the next year, the next 2 years, we're going to see more uptake and be able to provide even more answers on this. But to give you some basic examples, I think some of the places that we're seeing a lot of movement were, again, on things like 1115 waivers in Medicaid programs. I know that in Massachusetts, for example, we have our flexible services program that was approved under an 1115 waiver that allows our accountable care organizations to dedicate actual real dollars to addressing food and housing support needs for certain populations, including individuals that are chronically ill or pregnant or use the emergency room frequently. And the individual ACOs are allowed to decide exactly what those benefits look like, but several of the ACOs are looking into services that look like produce prescriptions, and those actual services are getting off the ground right now. So again, that's a stay tuned to learn more, but there are active partnerships on the ground that are happening. And then in North Carolina, we know through their approved 1115 waiver that they are looking at a range of nutrition interventions, which can include produce prescriptions. And again, like I said, I really look forward to the next couple of years. I think we're at an exciting moment where there's a growing knowledge of these opportunities. And so I think we're going to see it more and more. But there are actual on the ground important partnerships where we're seeing either direct sort of health insurance dollars filtering through the Medicaid and Medicare systems to these interventions, and also some on the ground healthcare institutions that are providing funding for these interventions. So I'm hopeful that we are moving away from dependence on philanthropy and hopeful to a more sustainable model. But as I said at the end of my remarks, I think there's work to be done. We need to elevate these opportunities and we need to expand them.
Yeah, and I would just echo a little bit of what Katie said and also say that we know that there are inequities in sort of especially in the Medicare program, right? You've got 2/3 of Medicare enrollees in traditional Medicare that has absolutely no access to food benefits through their Medicare, and then Medicare Advantage, in which the discretion is on the actual Medicare Advantage insurer about what they're going to choose to cover or not cover, or choose to more accurately apply to CMS to cover or not cover, and sort of see what CMS says. So we do want to point that out. So we can do more to really go at the heart of what these Medicare and Medicaid programs cover. Otherwise, it will be on sort of the strength of the evidence base that we get in terms of cost and utilization, most likely, that will really drive the bus on whether that's integrated. And if we want to move away from that, we really have to figure out through research how we start to capture and then value some of the other impacts that we're seeing from these programs. And so we welcome the opportunity in Rockefeller Foundation with its investment in produce prescription, and the Aspen Food and Society program with its investment in the research. This is so important, and we have to be expansive in what we think we can achieve. In addition to really disciplined in sort of underlining the things that we know and deepening our knowledge of the comprehensiveness of our knowledge in those topics. So I think that's all the time we have today. We've really enjoyed being with you. Please look for a follow-up email that links to the slides and the recordings. We will provide links of how to get in touch with us in that email to hear more, to help us do more. We would love to hear from you. Your questions have been incredible, and we didn't get to them all today, so please don't hesitate to reach out. We hope you have a wonderful rest of your day. Thank you to all of our speakers and to Bridget and the Rockefeller Foundation for helping us to host this. And we will hopefully all see you in a future where Produce RX is more integrated into the healthcare and food systems.